Good evening. This is Dr. McDaniel. Today is Thursday, April 18th, and back at it with another live stream. Today, as the information I posted suggests, I'll be addressing a viewer's questions regarding leaky bladder. So, she simply said that she would like to know what the source of or why she's having bladder leakage issues throughout the day, and that she's having obviously a little bit soiled and unpleasant or pee smell underwear. She has to change her underwear or change pads twice a day. Now, what she didn't provide how long she's had the problems, and obviously I'm not going to have any access to her medical history. It was a question. So I'll give a bit of a background on what factors play into bladder leakage or urinary leakage, things that will exacerbate urinary leakage or mitigate it, and things that one can do to try to resolve the problem, and the evaluation, needless to say, that needs to take place in order to properly address it. So bladder leakage or incontinence, that encompasses several different entities. So first would be someone who doesn't have any clue that their bladder's full, they're perfectly fine, and then all of a sudden they cough, sneeze, run upstairs, hop over something, stand from a sitting position, and they have some leakage of urine. No warning, just squirts out. It's especially common with laughing or sneezing because those are forceful, increased abdominal pressure activities. We call that urinary stress incontinence. Now, I'll preface this with I'm not a urologist, but I deal with urinary issues quite a bit, being a gynecologist. Most women will come to me with the urinary issues. But the proper specialist for urinary problems, if you want a thorough or advanced evaluation, management, and treatment, that's going to be a urologist. That's a specialist, surgical specialist for the urinary tract systems. That's the bladder, ureters, and the kidney. And or a urogynecologist. That's a gynecologist like me who, after they finish their training, they take additional years to do subspecialty training in specific urinary disorders and problems that affect women. So the first is urinary incontinence due to increased abdominal stress or pressure. So we call that urinary stress incontinence. We used to call it genuine stress incontinence. A second factor would be when someone feels like their bladder's full, they can usually hold it, or they'll end up forgetting about it, delayed, and they'll feel like their bladder's full, but they can hold it, maybe delay having to go to the restroom for an hour or two. They feel fine, and then suddenly, as soon as they get home or to the place where they want to use the restroom, or as soon as they start to disrobe in order to use the restroom, the urine just starts squirting out rapidly, quickly, and strongly. That we used to call keyhole incontinence, because it's as soon as they get their key in the door, their key in the door or the keyhole for the door, they start to have incontinence. Some people call that detrusor instability because it's a reflex from when your mind is telling you you're close to being able to relieve it. Then the reflex kicks in and the bladder starts to spasm or contract and the urine is lost. Another type of urinary loss is when someone, the urethra, the sphincter, the juncture of the urethra doesn't close properly or well. So when their bladder starts to get full, it just starts to leak. So the sphincter is very, very weak. That type of urinary loss is often due to neurologic defects or scar tissue, problems with the actual tissue makeup. So there are several types of urinary loss, and then in addition to that would be just plain urinary leakage. So another form of detrusor instability, where as the bladder starts to get full, instead of relaxing to allow the bladder to fill, the muscles of the bladder start spasming past a certain point. So as soon as the bladder starts to get full, even when you don't realize that it's full, you start to have some squirt or leaks of urine. So there are different types of urinary loss, and from different sources, etiology, reasons behind the loss. But if someone has urinary loss, the first thing we always do is we send their urine to check to see if there is a bladder infection, a cystitis, a UTI. So cystitis or bladder infection, the bladder is a sterile environment. If bacteria gets into the bladder and it's allowed to build up, bacteria causes inflammation because of the infectious process. Inflammation will destabilize the bladder muscles, and the muscles will start to spasm and contract. You can lose urine. You can lose it out the blue randomly, or as your bladder starts to get full, it'll start to squirt out, or you just can't hold it very well. Or you feel like you're frequently, just every 15-20 minutes, you feel like you have to go to the restroom, your bladder's full because of the spasming and contracting of the bladder. So the first thing we always do is we send the urine to see if there's an infection. And we call a bladder infection a cystitis. That cystitis can be a new phenomenon, so we call that an acute cystitis, or it could be smoldering, lingering, causing symptoms and problems for weeks or months on end. That's a chronic cystitis. Regardless, the treatment is antibiotics. You clear up the bacteria, you clear up the infection is cleared up, you're going to get rid of the inflammation, you're going to be fine. That's the first part. So a urine culture. In addition to that, a urinalysis is sent. So the urine is evaluated to see if there are potential factors in the urine that's doing the same thing as bacteria would do, but obviously it's not bacteria, it's factors in the urine, because any inflammatory process can give you the same scenario with spasming of the bladder muscle, the detrusor muscle, and then urinary loss. So small crystals that could be evident or a source of kidney stones. Acidity changes, so highly acidic urine will sometimes cause spasming and urinary loss, and sometimes blood present in the urine can indicate that there's a stone, an inflammatory process, or even an ulcer or a polyp, a growth, a mass that's causing the bladder muscles to spasm and contract. Urine culture, urinalysis. Urine culture for an obvious bacterial source of infection, urinalysis to look for clues, kind of like Sherlock Holmes, for clues that there is something physical that's an irritant in the bladder muscle and causing spasming, contracting, urinary loss. After that, of course, the history is important. When does this person lose urine? Because when they lose it and the factors surrounding when they lose it may indicate why they're losing it. The most common source, if it's not infectious, it's not something physical, it's going to be the stress incontinence. That's one of the most common sources for women for a few factors. Anything that increases abdominal pressure inside the abdomen, that will put pressure on the muscles of the pelvis. The pelvic muscle is like a trampoline. It holds up the bladder, it holds up the uterus, and it holds up the rectum. If the muscles of the pelvis are stressed, and they can get weakened, and they won't function properly. So it's like a trampoline, because when someone coughs or sneezes or does any kind of exertion, say they lift weights or something, that muscle is not supposed to collapse under that pressure. It's supposed to bounce back. So it pushes back against pressure that your body's putting down on it. And that keeps the bladder, the uterus, and the rectum all in the correct position. Now, along with the sphincter for the bladder stays in the intra-abdominal cavity to maintain the pressure dynamics with the muscle. If the bladder sinks or drops down when you cough, then that decreases the pressure, keeping the sphincter tight, closed, and it allows for urinary loss. Things that can push the pelvic muscle and weaken it and make it susceptible to being floppy and not pushing back when the pressure is made in the abdomen Anything that increases the pressure can do that over time. So the most common is going to be pregnancy. Pregnancy puts a lot of weight in the belly rapidly and for a relatively good chunk of time, 8 to 9 months for most people. That's going to put constant pressure in the pelvic muscles. In addition to that, the delivery process. So you have the 8 to 9 months of constant pressure in the pelvis. The pelvis is fighting back, pushing back to maintain its position. And then you also have the delivery. So if you have a vaginal delivery, that puts a lot of pressure and stretching of those pelvic muscles. So it's stretching them out, it's pressing down on them with the baby's head, and that destroys a lot of fibers and tissue, and it weakens it. Every time you have a vaginal delivery, it's going to weaken those muscles more and more and more. So the most common reason for having urinary loss or stress incontinence is pregnancy. I guess those are two reasons. The third reason is going to be increased weight. So whenever you put weight on, especially if it's belly weight, that weight, gravity, is pushing it down on the pelvic muscles, and it's putting a constant source of battery, basically assault and battery on the pelvic muscles. And then in addition to that, any exercise that you do. So if you're doing especially weightlifting where you're exerting yourself and grunting and bearing down, that's putting pressure on those pelvic muscles. Constant aerobics, gymnastics, those are all activities that put increased abdominal pressure. Any kind of frequent, constant, or exerted pressure on the pelvic muscles is stressing them. And stress makes the tissues weakened and more susceptible to being floppy and having loss. So you cough or sneeze, the muscle can't push back to maintain the bladder sphincter closed and its position correctly in the abdomen, you're going to lose urine. That's the biggest factor. Now, as far as the evaluation goes, after the cultures, after the urinalysis, after the history to see what the scenario is around that process, is going to be an ultrasound or a sonogram. The sonogram is going to look at the bladder, the ureter, and the kidneys. So kidneys are here. The conduit or the route between the kidneys and the bladder are the ureters, the bladder, and then the urethra, which is the spout that allows the bladder to pass the urine into hopefully your toilet. So the sonogram is going to evaluate those structures to see if there is a physical source for inflammation, and with inflammation will be spasming, destabilizing, contracting, and appropriately so, of the bladder muscles and causing urinary loss. It's going to look to see if there's a polyp, which is an abnormal ball of blood vessels, a mass, a growth, a tumor, benign or cancerous, malignant, any obvious stones, kidney stones or crystals, any divots or diverticula. Those are all the usual suspects that you can see on an ultrasound or a sonogram. Some people will add an x-ray to that because certain kidney stones can't be seen on an ultrasound because of the nature of their makeup. They can only be seen on a an x-ray of the kidney, ureters, and the bladder. Call that a KUB. And then after that, depending on what that evaluation process shows, is a camera evaluation. That's called a cystoscopy. Cyst means bladder. So a bladder infection is a cystitis. Looking into the bladder is a cystoscope. The scope means to look, so it's a camera that looks in the bladder. So we look in the urethra, the bladder, and evaluate. Same thing for any tissue aberrations or physical problems that couldn't be seen on the ultrasound, couldn't be seen on the x-ray, but will need to be eyeballed directly to be seen. If any abnormal findings are discovered, then a biopsy is done. After that, most people will get an evaluation called urodynamics. So urodynamic or 3-chamber urodynamic testing is done to evaluate how your bladder responds to your body filling it up. So an evaluation is done to see, first off, how much urine is left in your bladder when you feel your bladder's empty. That's called a post-void residual. So void means emptying your bladder or peeing. Post means afterwards, and residual means whatever's left over. So the person urinates, and then a catheter is placed to see how much urine comes out once she feels like her bladder is totally full. It should be a very small amount of urine, less than 10 cc's. So let's say 10 cc's is like maybe 2 tablespoons or so. Some people surprisingly will have a huge post-void residual. They'll have like a cup of urine sitting in the bladder and they feel totally fine. So of course, by the time they feel like their bladder is full, their bladder is over full, it's over distended, and the least amount of provocation, or even right before they feel their bladder is full, least amount of provocation is going to make them leak because their bladder is over full. So the post-void residual is done, and then catheters are placed in the bladder to see what kind of pressure response the bladder exerts to activities, and the next catheter would be placed in the vagina for women, in the rectum for men. So it's bladder and then vagina, and then some people will still place the third one in the rectum, is to see what kind of pressures your body's exerting, so what kind of abdominal pressure is placed, and then how the bladder responds to that abdominal pressure. So the person will, and then a catheter is placed also in the urethra to fill it up. So the bladder is filled up to simulate urine, and then the person is monitored to see how the bladder spasms or contracts in response to the bladder filling up. So do you have abnormal spasming, contracting, and urinary loss as the bladder normally fills up? When you cough, sneeze, or anything, does the bladder abnormally contract? So that urodynamic testing is an objective way to evaluate if your bladder muscle is responding the way it's supposed to normal filling of the bladder and activities, or is it responding abnormally? I think I'm going to cut it off there because it's been I'm trying to keep these short and sweet, so I'm trying to keep them around 10 minutes. It's been more than 10 minutes. So that's the evaluation process. Tomorrow's Friday, so tomorrow I'll do a second half, and the second half will be what findings can occur on the testing, what kind of categories we put people in, things that one can do potentially homeopathically or naturally at home to decrease urinary issues, and then what kind of medical treatments, so medications and or surgeries, are usually recommended or offered to address urinary loss. Thank you for watching. This is Dr. McDaniel on Gyn Corner. We're here in Manhattan, New York City, Midtown, around the corner from Macy's. So if you're in town, you want to come by, we do walk-ins every day, and we have office hours depending on the day. It's between 9 a.m. is the earliest, 6:45 is the latest. So come on by. We take lots of insurances. You can call the office. Thank you for watching, and I appreciate the questions. So if anyone has a question, they want to pop it into the message box for the Facebook page, I encourage you to do so. It makes it easier to give the live streams. I can always come up with things that I see in the office here. I was prepared to do something different today that's come up in the office 3 times today with 3 different patients. We saw a good number of patients today. But when I got this question, I try to answer these viewer questions the same day or the next day because it just makes it nicer for them. And I don't have a fixed agenda. It's just I'm kind of going with the flow. So I appreciate the questions, and I'll do a part 2 tomorrow. Thank you for watching, and have a good night. Bye.